Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Österreichische Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie, Dialyse et Transplantation, Marcus at Home welcomes Professor Johan Sundström and Dr. Ollie Östlund, with whom we would like to discuss their PHYSIC study, a landmark study in hypertension research, published in JAMA a few weeks ago. The study investigated and quantified the potential for targeting specific antihypertensive drugs to specific individuals in order to maximize blood pressure effects, or in more simple words, does one type of an antihypertensive drug fit all our hypertensive patients, or should we individualize drug choice with patient A receiving drug A and patient B receiving drug B? So thanks a lot for taking the time, for being with us. It's a pleasure to have you tonight.
Thanks, Gunnar, Stephan, and lovely to be in your beautiful show.
Yeah, thank you very much.
Dr. Sundström is professor at the Department of Medical Sciences, Clinical Epidemiology at Uppsala University, and conjoint professor at the George Institute for Global Health in Sydney, working together with Professor Neil, whose SARS study we discussed 2 years ago. His research group is leading a national initiative to further increase the value of the very comprehensive Swedish medical cohort studies and to initiate and conduct landmark randomized clinical trials, focusing upon cardiometabolic diseases and emergency care. Dr. Östlund is a PhD in mathematics and expert statistician in the Biostatistics group at Uppsala Clinical Research Center, which is a collaboration between Uppsala University and Uppsala University Hospital, and the leading academic research organization in Sweden, which manages clinical and observational studies, biostatistics, clinical quality registries, and clinical event education, and the largest Swedish center for national clinical quality registries, handling Sweetheart, among others. It's a pleasure again to have you. My co-moderator today is Stephan Schirmer, to whom I hand over the microphone.
Well, thank you also from my side for joining. We are thrilled to have the opportunity to discuss this trial. We alluded to it already. It's terribly important. I mean, in the clinical field, we give antihypertensive drugs all day, and we always wonder which one to start with. We have some guideline recommendation, which really leave everything open, all sorts of combinations. And we do hope to shed some light onto the most ideal and individualized therapy through the study. Dr. Sundström, I think we talked about some introductory words from your side. Maybe you can start by giving us some background and methods of the trial to make it understandable for us clinicians as well. So I'm happy to hear what you have to present. Thank you.
Excellent. Thank you so much. I'll actually take the opportunity to share some slides from the ESC of August of last year. We presented this as a late-breaking clinical trial study. We call the study Precision Hypertension Care, and the abbreviation is PHYSIC, and that's of course a play with words. Back in the olden days, you could either give your patients snake oil, or you could give them a tonic or a PHYSIC. So I'm not sure what they were supposed to do. The remnant we have today, of course, is gin and tonic, but the PHYSIC was probably equally ineffective as a tonic. I think the common denominator is that they all contain about 5% alcohol. So I just thought that was a fun abbreviation. So background for this is that, of course, the current hypertension care, at least as it's delivered in Sweden, but also in most countries except Canada, is clearly insufficient globally and also in Sweden. I don't know what it's like in Germany, but in Sweden, about 1 in 5 of people with high blood pressure reach the treatment targets. So business as usual is just not good enough. Guidelines advocate initial combination pharmacotherapy for most. And in Sweden, about 1 in 10 get an initial combination pill, a fixed combination pill, or actually 2 pills in combination. So that's still just 1 in 10, even though these guidelines have been around for quite some time. They perform really well in randomized clinical trials, the combination pills, and our friends in Sydney who did the quartet trial show that very nicely with even up to 4 molecules. but I think the translation of that into clinical practice has been slow, and I'm not sure what the reason for that is, but it's possible that there are performance biases that show up when you try to translate that kind of study results into clinical practice. So what we wanted to highlight with this study was that the potential for personalized monotherapy is unknown. It's never been tested before. There have been a number of different trial attempts to do this, but we'd like to say that no one has actually used the adequate study design to quantify the personalizability yet. And we'd like to think that we've done that now. But we'll take you through that pretty complicated mechanism. So the hypothesis there is that there is a potential for precision medicine in hypertension, and by precision medicine we mean that there is one optimal drug for every person. So let's think about how to scope the potential for precision medicine. In a parallel group trial, you get one blood pressure value per participant, and here we've just drawn an arbitrary response criteria, and that is historic blood pressure of 140. So you can sort of think about this as some patients are being apparent lisinopril responders, and other patients being apparent candesartan responders. But they only tried every drug once, so they only tried one drug each. So we don't know how they would respond if they got the other drug, right? So this is an inappropriate way of analyzing responders and non-responders to the two different drugs. So an alternative would be a single crossover trial. Here we get one treatment difference per participant, and because everyone gets both drugs. So we've just highlighted an arbitrary response criterion here, and we said that a difference of 10 millimeters of mercury in favor of one of the treatments indicates that you're a responder to that drug and not to the other. So some participants seem to be lisinopril responders here in pink, and others seem to be candesartan responders here in blue. But if we repeated the crossover, would the same patients be lisinopril and candesartan responders the second time? And that is really the key question here, because there are so many things that vary between the treatment periods. The season, that I personally know that my body weight is 3 kilograms higher in January than it is in July. And if I got the lisinopril arm when I also had the flu, that would affect my blood pressure. If I got the candesartan arm when I had just broken my arm and took painkillers, that would affect my blood pressure as well. And concomitant other medication, of course, will affect blood pressures. So we don't really know what would have happened if we gave the same treatment contrast a second time. And that is really the key here. So we turn to Stephen Sen. I asked Ollie for help to design this study, and I only had thought of giving each person each drug once, but Ollie cited Stephen Sen and told me that I need to give them each drug twice, and this is the reason. So Stephen Sen has done modeling studies in asthma, and I think that's where he's spent most of his time at that clinical field. So here he has a modeling study that looks at a drug versus placebo in affecting FEV1 in someone who probably has some kind of pulmonary problem. So he's then highlighted some kind of response criteria. So people here to the right of that response criteria, above 0.3 or something like that, increase in FEV1, difference to placebo, are responders in a first crossover. And then you give patients a second crossover. You give them the drug and you give them the placebo again. And here you see that there are responders to the drug in comparison to placebo, also at the second crossover. And if the outcome is something like this, that the same patients in both crossovers are responders. So these patients up here are responders in the first crossover, and they are responders in the second crossover. These patients here are non-responders in the first crossover, and they're also non-responders to the second crossover. If this is the case, when you do this repeated crossover trial, then there is a place for precision medicine here. There are winners that could be picked. You can pick the winners that should have the drug and that should not have placebo. And you can also pick the losers who should not have the drug because they have the same response as they have to placebo. So this scenario would indicate a potential for precision medicine or for personalizability in this treatment. But if the scenario is this instead, then there is no potential for precision medicine here. So you'll see that some people were non-responders in the first crossover, and some of those are actually responders to the second crossover, etc. So this is the design quirk that we want you to have in mind when we look at the results here. So is this picture, there is a potential for precision medicine. For this picture, there is no potential for precision medicine. I'll just quickly go over the design of the PHYSIC study, because this is what we did, a repeated crossover study. So we did a randomized, double-blind, repeated crossover trial. We think it's the first, but people are, we're happy to have feedback if this is not the case. For a primary outcome, we used ambulatory systolic daytime blood pressure assessed at the end of each treatment period. Of course, we need this to be a double-blind study because of placebo effects or nocebo effects to some of the drugs. And we need an ambulatory blood pressure measurement, of course, because we're looking at subtle differences in blood pressure, so we need to make sure that we measure the blood pressure as well as possible. We had 6 treatment periods per patient, 4 classes of blood pressure-lowering drugs in monotherapy, in opaque capsules, and 2 drug classes per patient were repeated. So, and this is just to illustrate what happened. So everyone got an ACE inhibitor, everyone got an ARB, everyone got a calcium channel blocker, everyone got a diuretic, and then we repeated 2 of those in each patient, and different patients repeated different drugs. In retrospect, we probably would have wanted to repeat all 4 drug classes, but per patient, the study ended up being 12 months long anyway, so we just thought we couldn't keep them for another 4 months, and that was the reason for this design. But we powered it so that equal numbers of patients repeated each contrast here. And this is just for illustration purposes. The order of the periods were randomized individually, so it didn't look like this, or it could have, but it probably didn't. So patients could actually get 2 ARB periods right next to each other, for example. We had 2 weeks of placebo run-in, and they got rid of their previous blood pressure lowers. About 2 out of 3 had some initial monotherapy for their high blood pressure, and 1 out of 3 were treatment naive. Treatment periods were 8 weeks long, and we had a half dose of the drugs for the first 2 weeks, and then up titrated to the target dose, and the target dose of at least 5 weeks and usually 6 weeks. And then 1 week of placebo washout between these treatment periods, and that was just to minimize side effects pretty much, because the blood pressure effects are probably ripe for evaluation already after 4 weeks in the target dose. So in all, 8 weeks per treatment period, half dose titration the first 2 weeks, and then target dose at weeks 3 to 8, 2-week run-in before the first treatment period, and a 1-week washout between each period. So that was a design in a nutshell. So we try to do a double-blind, randomized, repeated crossover trial. I don't know if you've heard anyone do it before, and if so, please tell us, or if your listeners can reach out to us, that'd be great. So I'm not exaggerating the
well, I don't think, definitely not for blood pressure. We know that, right? Possibly for if you look at it in one direction, it's a repeated crossover study. So you have crossover studies and you repeat it. If you look at from an orthogonal angle, it's a repeated N of 1 trial, where you do an N of 1 trial, but in several patients. So N of 1 trials and repeated N of 1 trials have been done. The repeated crossover was, I think it mostly appeared in some bioequivalence trials a couple of decades ago, when it was when it became popular to talk about individual bioequivalence, but it's not that hot anymore.
That's right. It's from a patient perspective, it's an N of 1 study, and we actually, at the end of the study, everyone got a visit to an independent doctor that could be unblinded. And all the patients then got to see their 6 treatment periods. They got to see their 24-hour blood pressure. They got to see all the side effects that they reported. And then they got to rank the order, their sort of the favorite treatment period, and then sort of least favorite. So they put out the numbers 1 to 6, of course. And they had some skin in the game, because we said that the one that you determine is your favorite treatment period, you're going to get a prescription of that drug. So then we opened the envelopes and we looked at what the molecules were in these treatment periods. And then they got a prescription for their favorite drug. So for the patient's purposes, it was an N-of-1 trial, and it was used as an N-of-1 trial. But in difference to N-of-1 trials, this was actually powered to draw group-level conclusions on as well. The N-of-1 design is just for individual patient conclusions. So that, I guess, is the difference to the Samson trial or the statin-wise trials, which are beautiful trials in statins that I urge you to look up if you haven't already.
I mean, thank you so much. The design with the very well conducted washout period, the run-in phase, and the ABPM measurements, I think that's wonderful and really gives us clinical significance. I have a few very simple questions. One of them is, why would you do daytime ambulatory blood pressure continuous monitoring only? Why not 24-hour as usually? That's one question. And then the other one, you alluded to side effects already, which the patients discussed in the end. You don't have serum available of everything. I'm sure you didn't measure everything, and also the time periods, even if they were 8 weeks, are probably too short to cover all side effects, or not?
Great question. So let's start with the first one, which was that why do we use daytime blood pressure? Well, the idea is actually that if we want something that is clinically applicable at the end of this, we probably need to have something less expensive than a 24-hour blood pressure and an N-of-1 setup, whereby you get every patient a 24-hour blood pressure regimen repeated times. So I think that the idea of doing a daytime blood pressure as the outcome is that it could be sort of replicated using home blood pressure monitoring. That is at least the idea here. But we could have gone for 24-hour, but that's the problem when you use an ambulatory blood pressure monitoring. There are so many different blood pressures to use. So this is the one we settled for. The other question was, what about side effects? So we purposely actually gave everyone a side effects questionnaire. There isn't one validated, but there is one, I think it's from Spain, it's called PHYSIC, that we used in this study. And patients got either a bunch of those to have at home or an app where they could fill that out. And they were prompted to do this every 2 weeks during each 8-week period. So we're going to get some results on the appearance of side effects, when they start, if some of them then decline over time, or if some are persistent over time. But the one that was shown to the patient at the end of the trial was the one that they reported with the study nurse at the clinic at the end of each treatment period. We have a large chunk of side effects data that we're just diving into at the moment, that we're just waiting for Ollie to get some time to do that. But that's actually we had a hard time settling on the primary outcome for this study. We settled for systolic blood pressure because it's so well behaved. It's normally distributed. It has a great variance, so it's sort of the perfect case for personalizability questions, because there are so many variance components to systolic blood pressure, and it's normally distributed. So, but actually, side effects was up there, competing with us, because we think if the problem is that people are not adherent to their blood pressure lowering drugs, and personalizability from a patient perspective is probably finding the one drug that doesn't give you side effects and sticking to that drug instead of getting one. If we recommend 4 drugs equally warmly, as the guidelines do, and there's one optimal drug for you that gives you 0 side effects, and 3 drugs that give you some side effects, of course, there's a 75% probability that you'll get the wrong drug, right? You'll not get the wrong drug. So it was a sort of a hard decision between having side effects and systolic blood pressure as the primary outcome of the trial. So we're just dying to look into that, and we'll be back with those results that I think are going to be equally important. Just to say also that systolic blood pressure was hard for Ollie to model, and he's probably going to, if we have the time, you could talk an hour about how to calculate p-values in the studies, for example. But side effects, we have 20 different side effects, so that's a much harder question. How are the studies
side effects? It's also a harder question because it's less easy to say what is an individual effect here, because with blood pressure, it's not only very well behaved, it's very well behaved on like a scale that everyone understands. So side effects are will always be presented on some strange scale. And the thing with individual effects, that the treatment effect that we estimate is different between patients. It can differ depending on what kind of difference we use. So if we were just looking at did you have cough or not, then we could look at, okay, how many percentage points more likely were you to have cough, or how many percent on a relative scale, or how much larger odds did you have to have cough? And depending on which of these scales you choose, you will find different kinds of personalizations, because like a doubling of the frequency of cough, if you have very little cough, it's a very small absolute difference. If you have lots of cough, it's a large difference. But it's the same difference, so constant between patients, perhaps on a relative scale, but not constant on another scale. So interpretation is also harder.
I also have one more stupid question, maybe, because we are talking about individualized treatment and N of 1 or individual crossover trial. But obviously, it's a 280 patient study, I think, with a lot of crossovers, to put it simply. But we do get a group result, of course, somehow. So how can you, or how can we in practice, but we'll come to the results and maybe we discuss it then, how can we make a conclusion, draw a conclusion on individualized therapy from that? Because would that mean in the end that we have to, with our patients, go through all treatments to make sure that we get an individualized ideal treatment? Because it will be different in everybody. We don't have anything to forespell.
That's a great question. I think maybe if we dive into the results, we're going to see if we can exclude
Gunnar,
some of the myriad of possibilities here and just focus on some of the contrasts. Maybe that's one way to start, and then we can talk about how do we translate this into clinical practice, because that's a hard one.
Maybe just two brief method questions from my part. Why did you choose, when it comes to thiazides, why did you choose HCT or not chlortalidone? In the hindsight, surely we learned some months ago that they are really virtually the same, but when you designed the study, you did not yet know. So why did you decide HCT? And I guess it's obvious why you didn't include a beta blocker, but at least here in Germany, we still see so many patients with hypertension without any cardiac complications who are on beta blockers, which are actually no longer first-line treatment, surely. Is this less a concern in Sweden than here in Germany?
I think beta blockers are pretty much out in Sweden for as a first-line drug in high blood pressure. And I think it's been quickly replaced by MRAs, which is, I think, have much better evidence for them. So that I think, and plus, I mean, to be congruent with guidelines, beta blockers wouldn't be an option here. So we tried actually to find inclusion criteria that would fit into current European and American guidelines on having low-risk patients with grade 1 hypertension and no specific indications for any of these drugs. So I think there's still room, some wiggle room in the guidelines of these are people that you might consider monotherapy for, even though, of course, combination therapy is recommended for most. So yeah, no beta blockers here. And why did we not use? Well, I personally like chlortalidone, but it's a very small issue in Sweden. And one of the reasons for the individual drug choices was that they had to fit into our capsules. So all the pills were over encapsulated. So that was actually one of the bigger variables that went into the choice of the actual pills. But they're also all first-line drugs in Sweden. Yeah. That was the reason. Let's look into some results here. Ollie, I'm probably going to have your help in disclosing what we found here. So let's start by saying this first slide shows the actual measured blood pressures, and it's just to show the sort of variance components in here. And I think the heading says it all. We found a large variation in blood pressure between participants, between treatments, and within participants on the same treatment. So you see here that highlighted here is one patient that had one trial of Kaiserslautern on the X and one trial of hydrochlorothiazide on the Y. This patient had one period with Kaiserslautern and 2 periods with amlodipine, and the ends of the whiskers are the blood pressures measured at those 2 different amlodipine treatment periods. And this patient, for example, had two periods with the lisinopril and 2 periods with amlodipine. So the blood pressure variance between participants you can find on the diagonal. So some people were just high pressure people, and some people had a lower average blood pressure. And you'll see that there's some treatment, some variation in blood pressure between the treatments. So, for example, the hydrochlorothiazide was not equipotent to the other drugs. So you had a slightly higher blood pressure when on hydrochlorothiazide than on the other drugs, as you can see. Everything that has a hydrochlorothiazide in it on the Y, you have a slightly higher blood pressure there. So, and then within participants on the same treatment, you can just see that from the whiskers. So I think we established the various components that they are pretty large. So then we fit this model. This is a mixed effects model, and it contains conditional mean blood pressures from the mixed effects model. So this is model blood pressure. So you get just 1 dot for each patient on each treatment and in each graph. So these values include the average difference between the treatments. You get you get the person-specific overall systolic blood pressure on the diagonal again, and then you get the person-specific treatment contrast, and that's the most important thing here. So the further away the dots are from the line, the higher the between person variance in response. So you'll see that for some contrasts, there is a substantial spread of these modeled blood pressures from the diagonal line. So they indicate a fair amount of personalization potential. For other contrasts, the dots are pretty much on the line with a very low potential for personalization. This maybe is not so surprising for the lisinopril versus Kaiserslautern contrast. I mean, these are 2 drugs that work in the same hormonal system, so maybe you could think of this as not so surprising. To me, the hydrochlorothiazide versus amlodipine finding was a little bit more surprising, that there was no potential for personalization between hydrochlorothiazide and amlodipine. I've gotten some suggestions from people on Twitter, etc., that calcium channel blockers is actually slightly diuretic, so maybe that's one thing, but I'm just not sure about that. Maybe we can talk about that later. Ollie, do you want to chip in here? Any sort of insights you have from how to understand these graphs? Oh, I should probably say one thing, that the colors are just arbitrary, and the symbols are just arbitrary, just to make you disentangle the participants a little bit from each other.
Yeah, the colors are arbitrary, and actually the same patient is shown in several of these panels because we want to concentrate on differences between drugs, which means that we have 6 panels, although we had 4 treatments that the patients were on.
There's 1,468 dots in each of these graphs, pretty much, give or take a few. Some people were missing from some contrasts, but
yeah,
that's the amount of treatment periods we have. Yeah. So did I give a decent representation of the results? You think, Ollie, was that, or do we need to explain anything to anyone? You think?
No, I think it's a decent explanation of the results.
It's beautiful. It's colorful and nice, isn't it? So
yeah.
Just remember, the further the spread is from the diagonal, the higher the potential for personalization. And this pretty much indicates that there is no potential for personalization between these two drugs. So, okay. There we go. I'm actually going to show you this table as well. And this is a global model test. And do you want to tell us what the test was? How many parameters were in these two models that you computed?
Well, yeah. Blood pressure is excellent because it's everything is normally distributed. So standard linear models work very well. And what we are estimating here using a mixed effect model, which means that we model some things here as being random, really, changing between patients, but we do not necessarily estimate the actual values. The plot we saw before is kind of an estimate from the model for the individual patient values, but what the model really estimates is random effects, meaning standard deviations of randomness. So what we do is we compare one model where we allow each patient to have a kind of average blood pressure, which can vary between patients. We also allow, we also fit a fixed treatment effect, fixed average treatment effect, so that we kind of take care of an average difference in the population and treatment effects. And this is the simple model. This is kind of the model that you would use to estimate these average treatment effects in a crossover study like this. But then we complicate the model by allowing the treatment effects to vary randomly by patient as well. So the marked p-value here is from a test comparing if a model that allows individual treatment effects fit the data better than a model that have heterogeneous treatment effects between all the treatments. And for the pairs, it's a similar comparison. So what we actually show here is standard deviations with the confidence intervals. So estimated standard deviations of these variance components within the participants we had in our trial. We estimate that the difference in millimeter mercury between amlodipine and lisinopril, this treatment effect varies among our participants with a variation with about 8.9 millimeter mercury standard deviation. And then we have a confidence interval for this standard deviation as well.
And just to put that in clinical context, this is pretty big, right? This is standard deviation of the differences in treatment effect. So for those four contrasts, that's pretty big. For these two contrasts, that's smaller and sometimes not significant. So this is sort of in numbers what you just saw in the graphs, the colorful graphs.
Do you mind if I interrupt at that point?
Sure.
Just alluding to what you just said, I mean, we if I understand you correctly, we get up to 8 to 10 millimeter mercury difference between two drugs on average between individuals. Is that right, or is that because that's almost one whole blood pressure tablet effect? That would be huge.
I mean, I guess this is, you can think of it as the distribution here, right?
But that's the largest, but with the lowest
distribution.
Yeah, we model this random treatment effect as a normal distribution here, and that seems to fit quite well. So it's the standard deviation of a normal distribution, really. So most of the patients will not have that large individual effect compared to the average treatment effect, but some patients will be out there with quite large difference as modeled by this method.
Okay. Mm-hmm.
Yeah.
So I'm gonna actually jump to this panel. So here we did something complementary, and this looks very much more like the Stephen graphs of FEV1 that I started out with to introduce the method. This is just people who had 2 crossovers of each of the respective contrasts. Everyone in this panel had 2 trials, 2 periods of amlodipine and 2 periods of Kaiserslautern. And it's somewhere between 40 and 50 in each of these, very cleverly randomized by Ollie. So, you know, so these are now differences in systolic blood pressure in the first crossover on the X and in the second crossover on the Y. So you'll see that some people had a pretty large, consistent difference between these 2 drugs in the same direction. So people down here had between 15 and 20 millimeters lower blood pressure on one of the treatments than on the other, and the same in the opposite direction here. In contrast to some of the contrasts, like Kaiserslautern again, the 2 RAS inhibitors, where there is, as we said for the Stephen graphs, no potential for personalization. Here, there are no winners to be picked here. Here there are winners that you can pick potentially. And so this again gives us the results are sort of summarized in a table like this. And this very cleverly also expressed by Ollie. If you have a first crossover where there is a 1 millimeter difference between one drug and the other in one direction, what is the mean difference in the second crossover per millimeter mercury in the first crossover? So if you have a 10 millimeter difference in the first crossover, then you're going to have a 7.1 millimeter difference in the second crossover on average in this treatment contrast. So that's a pretty clever way of expressing it, I think. This is sort of the predictability of the second crossover from the first crossover, and it shows you that there is a significant difference in the same direction as in the first crossover.
Yeah.
So that is sort of in clinically interpretable, if you wish, because it's on a scale that is understandable.
Yeah, well, what you really would like to find is perhaps a biomarker or some other predictor of which drug to use. And here we use here we use a one-time crossover within a patient to see if that predicts the difference. So it's kind of an optimal predictor in some sense.
Yeah, it's using the exact same experiment to predict the outcome. So that it's possible to do that, and for some of the contrasts, but not for the others, again. So our conclusions here is that there is potential for personalized monotherapy for hypertension with this global test of allowing the treatments to vary between patients, and that is actually a better model fit than a fixed treatment effect for all. And a personalized choice compared to on a random choice of treatment between these 4 would on average give you 4.4 millimeters lower systolic blood pressure. Ollie, you sometimes, I think, said that comparing to the worst possible choice, the least optimal choice, that we could double this, that would be 8.8, wasn't it?
Yeah. You can just double it, the worst choice is 4.4 worse, and the best choice is 4.4 better. So, and this is for our participants.
Yes, and these are very average participants, patients that have an indication for monotherapy, they're low risk, and given a choice of 4 different drugs, picking the best one, it gives you a 4.4 millimeter lower blood pressure than a random choice. And if you by accident pick the worst one, because there is a best one, then that would on average give you an 8.8 millimeters lower blood pressure. And that, I think, is a substantial effect. And we should say that these are all on-treatment blood pressures. So this is not, compared to 0 or the only blood pressure lowering that they get. This is 4.4 millimeters better than the average treatment effect here. We think that there was a notable personalization potential for 4 of the contrasts. And I don't know if you noticed, but these were choices between a RAS inhibitor and a non-RAS inhibitor for all of those contrasts. But for 2 of the contrasts, the 2 RAS inhibitors and the 2 non-RAS inhibitors, there was no important personalizability. We also like to give kudos to the inventors of the repeated crossover trial design, Stephan and friends. And we think that this is a really interesting study design to determine potential for personalized treatment choices for, and we say for chronic conditions where there is most of all, a continuous biomarker like systolic blood pressure that is so well behaved, but it's potentially extendable to other similar scenarios, of course.
I like to really emphasize this thing that we're able to rule out things here. If we hadn't done a repeated crossover trial, but just let the patient test each drug once, what we could have, the only thing we could have done later was to look at patients who in their single crossover had better blood pressure on Kaiserslautern than on lisinopril, and then try to find some biomarker for that. But from this trial design, we know that that's just noise. Then we would have been looking for and probably finding biomarkers for noise.
Yeah. And I think we're coming to this understanding. This is just to illustrate the Stephen model again. First crossover, second crossover. This again was lisinopril versus Kaiserslautern. And so this is the same differential response criteria. I don't know if you remember the first crossover that we had. Some people were Kaiserslautern responders and some were lisinopril responders in the first crossover. But in the second crossover, of the 5 Kaiserslautern responders in the first crossover, these 5, 1 is actually now none was a Kaiserslautern responder at the second crossover, and 2 were actually lisinopril responders instead. And out of the original lisinopril responders in the first crossover, only 1 remained at the second crossover here, while 1 had actually become a Kaiserslautern responder. And as Ollie said, if you just had this, you would definitely find biomarkers for those people and discriminating them from those people. And this is just noise. And I think that was an important understanding from this trial, that you really need to do the crossover twice at least, and potentially even more times. I'm trying to figure out if if our friend Katie Bell in Sydney, she did some interesting modeling from a couple of ACE inhibitor versus placebo studies where they measured blood pressure sort of annually on treatment, and you could get sort of a within person variance components from that setup as well. So there might be other ways of approaching this, but this was sort of purposely done to randomize the treatment periods around the calendar year, etc. So you need to sort of make sure that you're not accidentally measuring blood pressure at the same season in each patient, for example. So there might be ways to do this without doing it the hard way that we did. But I think we need to understand more about how to approach it.
Yeah, using repeated measurements require more assumptions, but given reasonable assumptions, you can perhaps use that in at least in some situations. One benefit here is also that we have blinding in a different way, perhaps.
Perhaps more important when studying the side effects.
I know that the study went on for 8 weeks per treatment. Could you speculate on the durability of the response? Because what patients keep telling us in clinical practice is that they have been on amlodipine for 10 years and suddenly it's not working anymore. Now my blood pressure is going up. We all know these kind of things, and we say, well, that's not true. You just need another drug in addition, and you're getting older, it's not well controlled. Would it be possible to that the treatment efficacy individually changes actually over time?
Well, first of all, I think there are some sort of key insights about how blood pressure works that we need to remember. We need to remember that blood pressure increases with age, in untreated people, but also in people who have monotherapy. They're going to eventually need another drug. So, and of course, there's an over-reliance on measured blood pressures in the clinic to monitor people's responses because there's just so much variability going on in its blood pressure. So a single clinic blood pressure is just not going to be very useful for finding out people's blood pressure. So that is one insight. And of course, another insight is that most people would need more than one drug at some point to control their blood pressure. So we're only just scratching the surface here and looking at the first period where some people might be eligible for monotherapy. We could do the same kind of study with combination therapies, of course, but the combinations are going to be multiplicatively more harder to study. We can do that.
I mean, actually, the data opened many questions to me in clinical practice, because if the variability is so large, we really need to change back and forth. As you said, also statistically, we would need several measurements and several repeated things. Then now it's May, so we're going into the summertime, and we all know blood pressure is going to go down. So all my patients never controlled, suddenly in July, August will have perfect blood pressures. Also difficult thing. Wouldn't we, with a total different perspective now, be able to get rid of all these problems if we just do, as has been proposed recently, do 3-4 tablets at the same time at a very low dose to start with?
Yeah, sure.
Mixture to everybody.
That would be a dream come true if it were that easy to just prescribe a poly pill and fire and forget. I'd love that if that worked. And I think the sort of Walden law hypothesis is still out there, and I think it's still probably doable. But I think I need some more evidence that is actually working in clinical practice, because we have so many strategies for lowering blood pressure, and blood pressure control is so bad in society. So why is there such a discrepancy? Is that just because people who treat people with high blood pressure just don't care about their blood pressure, or is it really hard to know what blood pressure someone has? And I just think that the current paradigm isn't working. Poly pills or combination therapy is part of the current paradigm. Not a lot of people are getting it in Sweden. What's it like in Germany? Do you often prescribe a fixed combination pill as initial therapy? It
is a cost issue indeed. We are, by the insurance companies, we are sort of forced or at least urged not to use, and that is contradictory to the guidelines, not to use combination of RAS inhibition and calcium channel blockers.
Really?
With sort of quota in prescription for that, so that's no good.
Wow.
That's different with combination with diuretics. That's easier.
Yeah.
But we're really, because it's mildly more expensive in Germany, but mildly really, but it's still there's sort of a blockage there by the insurance companies.
Yeah, I'm really interested in our side effects work that's ongoing now, because if also some reports, I mean, there's this one WHO paper that says that adherence to blood pressure lowering therapy is somewhere around 50% after a couple of years. I've seen other studies, and we have actually a PhD project going on that says that it's probably somewhere near closer to 60 or 70% after a couple of years. It's still really bad. So if side effects is one driver of that non-adherence, because people just don't feel their high blood pressure, it's symptomless, but they do feel their side effects, and they're just not going to take the pill. They also notice themselves that blood pressure is so variable, so it doesn't seem to matter that I take this drug. So if you have now, out of the 4 recommended drugs, there's one optimal drug for you that gives you 0 side effects and an optimal blood pressure lowering, and the other 3 have some amount of side effects and some amount of worse blood pressure effect. A combination pill, of course, is one way of making sure that you find this one drug that gives you the best blood pressure lowering, but it will likely also give you some of the side effects that come with the other drugs. So And I think that is the problem. If you can show it in the Quartet study that people happily took their quad pill and had low side effects, if that is translatable to clinical practice, I'll jump on that bandwagon any day. But I'm just not sure that that is how people in real life think about their primary preventive treatment, because non-adherence is such an important question. But that I just think that what we've done here is we've given doctors one more tool in their toolbox of how to find the right drug for the right patient, or how to treat blood pressure targets. Some people might happily go along with polypills, and that's perfect. Some people will question that and not take their drugs, and maybe this is another way of finding the right drug for the right patients. So that's a sort of pragmatic way of looking at it. We could go into details of asking, what would the contrast be that you would then try out if you were to test this at home, sort of in your clinic. So we could say you don't have to challenge lisinopril with candesartan, for example, because there is no personalizability in that contrast. But you might want to try a RAS inhibitor and a non-RAS inhibitor. That would be the things to try out. And for my personal preference would probably be an ARB and a calcium channel blocker. That would be the contrast I would try personally with my own patients. But that's I can't get that from this study really. But that's probably what I would do. How long do you need to have everyone on the drugs? I don't know. Can we find biomarkers that can predict the response? We're looking into that. We're following that up. We have a number of blood tests, and we have plenty of blood in the biobank, and we're genotyping everyone. It's a small study for a GWAS, of course, but we might go into some kind of target gene query. So there are a number of ways of trying to see how this fits into clinical practice. But for the moment, I think we've just proven the principle here, and how people use that in their clinic is really open for discussion, I think, at the moment.
But again, your data clearly show, as you just mentioned, it's finally the question, if we go for monotherapy, should we use either an ARB or an ACE inhibitor, which are virtually identical with regard to their anti-hypertensive potency, or should we go with a calcium channel blocker because the HCT was less efficient? And when we have this question for our individual patient in clinical practice, and neither physicians nor patients actually like to have 24-hour blood pressure measurements regularly, so each 2 months or so, would there be one option to ask the patient to monitor his or her blood pressure measurements at home, say for 10 days or so for each treatment period, and then to compare these 10 or so home measurements? Because obviously an office blood pressure measurement once the patient comes to us is not precise enough with all this variation.
Right. No, you need some kind of out-of-office blood pressure monitoring for sure to do this if you want to do the sort of N-of-1 setup. I'm sort of planning studies like that. I think I was initially sort of a tech optimist and hoping for the cuffless monitors that you could just apply to the patient, and it could sit on their wrist for 3 months, and you can do this whole N-of-1 setup within that. But a couple of recent papers just came out saying that their precision is pretty bad. So maybe that's not feasible at the moment. So, but some kind of out-of-office measurement. And I think I personally, in my clinic, use home blood pressure monitoring a lot. So, and I actually sometimes, against recommendations, sometimes prescribe them 2 drugs and say, alternate between these 2 and see which gives you the least side effects. Side effects is easier, I think. Blood pressure response is harder. Of course, the potential here is, 4.4 millimeters in this study with these particular drugs that we chose for this study. Adding another drug at a target dose will give you somewhere like 90% of what the first drug gave you. So depending on where you start, that's probably somewhere around 9 millimeters. Doubling the dose of the current drug you're on probably gives you somewhere around 2 or 2.5 millimeters. So it's somewhere in between those 2 strategies. Starting with one drug at one dose. If your choice is doubling or adding another drug at target dose, well, this might be another tool that might give you another 4.4 millimeters if you're unlucky not to get the optimal drug to start with, which you don't know. That's only group measure.
As nephrologist, I surely have to ask you, did you measure electrolytes after each period? So will we have data on potassium and sodium in the individual treatment periods?
No, so we did get blood draws at the end of each treatment period, so we have that in the biobank, but we haven't analyzed it yet. And if we get the funding, we might. Let's talk afterwards and see if we can find the money to do that.
Surely the nephrologist has to ask about hypokalemia and about hyponatremia.
Yeah.
And one additional question from my part. So surely the people in Uppsala are mainly white. There are few, if any, Afro-Americans included. There's the idea, and to my best knowledge, NICE guidelines from the UK still kind of turn to this idea that the response to different antihypertensive medication might differ between Afro-Americans and white people. Surely it's pure speculation, but if this study had been done in another ethnical population, would you maybe expect some other results, or would you expect them to be rather similar?
Good question. Ollie, do you want to think about that? I think if the heterogeneity in treatment response to one of the drugs was much bigger than for the other drugs, so the RAS inhibitors, for example, I'm assuming that the results would have shown a larger heterogeneity in treatment response, but I'm not sure.
Yeah, if that's how it works, but it's an interesting question because people, I'm a trial statistician, and I think usually people are overly concerned about trials having selected populations and being hard to generalize for that reason. But usually I don't think that matters very much because we measure treatment effects that are quite homogeneous on a well-chosen scale. But if you actually target personalized medicine, then suddenly my arguments don't work anymore, but the population that you include in your study is actually more of an interest. So if there is some gene that turns on or off some very specific thing that perhaps if we had completely different patients, we would have seen heterogeneity between those drugs where we don't see any now. But that's also speculation, and I think it's probably mostly a clinical question how we think this would generalize.
Yeah, that said, we did measure renin, aldosterone, and a number of other markers at baseline, so we'll have those to play with when we see if we can find any biomarkers that predict response to one versus the other drug. I think we can give a teaser already that the baseline blood pressure, the starting blood pressure, seems to be important for which drug to choose. We're not going to tell you which one to start with if you have a high versus low blood pressure. You'll have to check back with us.
Well, at least I learned so much in this discussion now on blood pressure treatment on the one hand, and also, again, a little bit on my very, very limited knowledge on statistics. Ollie Östlund, thank you so much, and Johan Sundström, this was excellent. And obviously, as in every good trial, you posted so many more additional questions, which makes us wonder about the future and hopefully be able to discuss with you again. Apart from blood pressure, you're involved in other trials, such as the SMARTEST trial. Again, looking at very, very relevant questions. Metformin against SGLT2 inhibition for diabetic treatment, anti-diabetic treatment. That's also something that we're really curious about. We don't have the answers. So really things that we are very much looking forward to seeing from you in the future. Thank you so much for all your great work there, and also for the discussion here. It was great having you.
Thank you so much for having us, and we really enjoy looking at your lovely channel. I try to follow it.
Thank you very much.